Hello, and now it's time for part two. We'll continue today the peptic ulcer disease. We finished the differential diagnosis from the case files books. Last thing we spoke of the differential diagnosis, and now we'll start with the symptoms. So, symptoms of duodenal ulcers. The classical symptoms of duodenal ulcers are caused by the presence of acid without food or other buffers. Symptoms are typically produced after the stomach is emptied, but food stimulated acid production still persists, typically 2 to 5 hours after a meal. They may awaken patients at night when circadian rhythms increase acid production. The pain is typically relieved within minutes by neutralization of acid by food or antacids such as calcium carbonate, aluminum, magnesium hydroxide. So, that was about duodenal ulcers. So, duodenal ulcers are caused by the presence of acid without food or other buffers. Symptoms are typically produced after the stomach is emptied, but food stimulated acid production still persists 2 to 5 hours after a meal. Awake patient at night, and the pain typically relieved within minutes by neutralization of acid by food or antacids. So that's the duodenal ulcers. The gastric ulcers, by contrast, are more variable in their presentation. Food may usually worsen symptoms in patients with gastric ulcer. Pain might not be relieved by antacids. So, gastric ulcers, more variable presentation. Food may actually worsen symptoms. Pain might not be relieved by antacids. And finally, we have gastric cancers. The symptoms of gastric cancers may present with this. Gastric cancers might present with dysphagia if they are located in the cardiac region of the stomach, with persistent vomiting if they block the pyloric channel, or with early satiety by their mass effect or infiltration of the stomach wall. They may present with pain symptoms as a result of ulcer formation. So, gastric cancers might present with dysphagia if they are located in the cardiac region of the stomach, with persistent vomiting if they block the pyloric channel, or with early satiety by their mass effect or infiltration of the stomach wall. And they may present with pain symptoms as a result of ulcer formation. So when it comes to investigations, who should do the endoscopy? Well, patients older than 45 years who present with new onset dyspepsia, they should generally undergo endoscopy. Patients with alarm symptoms such as weight loss, recurrent vomiting, dysphagia, and evidence of bleeding or anemia, they also should do endoscopy. And patients whose symptoms have failed to respond to empiric therapy also should do endoscopy. Biopsy samples can be taken to exclude the possibility of malignancy as the cause of the gastric ulcer. And biopsy specimens can be obtained for urease testing or microscopic examination to prove current H. pylori infection. In younger patients with no alarm features, an acceptable strategy is to perform a non-invasive H. pylori antibody test. The two most common tests are the urea breath test, and the H. pylori antibody test. If the symptoms are caused by H. pylori and not by the use of non-steroidal anti-inflammatory drugs, treat it with an antibiotic regimen such as clarithromycin and amoxicillin, as well as acid suppression with a proton pump inhibitor. So, that is if it was caused by the H. pylori. In patients and ulcers caused by the non-steroidal anti-inflammatory drugs, the non-steroidal anti-inflammatory drugs promote ulcer formation by inhibiting gastroduodenal prostaglandin synthesis, resulting in reduced secretion of mucus and bicarbonate and decreased mucosal blood flow. In other words, they impair local defenses against acid damage. The risk of ulcer formation caused by non-steroidal anti-inflammatory drugs use is dose dependent and can occur within days after treatment is initiated. If ulceration occurs, the non-steroidal inflammatory drugs should be discontinued if possible, and acid suppression therapy with an H2 receptor antagonist or proton pump inhibitor should be initiated. Okay, so non-steroidal anti-inflammatory drugs promote ulcer formation by inhibiting gastroduodenal prostaglandin synthesis, resulting in reduced secretion of mucus and bicarbonate and decreased mucosal blood flow. They impair local defenses against acid damage. So they should be discontinued if possible, and acid suppression therapy with an H2 receptor antagonist or proton pump inhibitor should be initiated. Hemorrhage is the most common severe complication of peptic ulcer disease and can present with hematoemesis or melena. Also, free perforation into the abdominal cavity may occur in association with hemorrhage, with sudden onset of pain and development of peritonitis. If the perforation occurs adjacent to the pancreas, it may induce pancreatitis. Some patients with chronic ulcers later develop gastric outlet obstruction with persistent vomiting and weight loss, but no abdominal distension. Perforation and obstruction are indications for surgical intervention. So, the most common severe complication of peptic ulcer disease is hemorrhage and can present with hematoemesis or melena. Free perforation into the abdominal cavity may occur in association with hemorrhage, sudden onset of pain, and development of peritonitis. If the perforation occurs near the pancreas, it may cause pancreatitis. Some patients with chronic ulcers later develop gastric outlet obstruction with persistent vomiting, weight loss, but no abdominal distension. Perforation and obstruction are indications for surgical intervention. Finally, just important points about the case. First, the most common causes of duodenal and gastric ulcers are Helicobacter pylori infection and use of non-steroidal anti-inflammatory drugs. Secondly, Helicobacter pylori is associated with duodenal and gastric ulcers, chronic active gastritis, gastric adenocarcinoma, and gastric mucosa-associated lymphoid tissue. Lymphoma. Gastric mucosa-associated lymphoid tissue lymphoma. It is not definitively associated with non-ulcer dyspepsia. Thirdly, treatment of peptic ulcers requires acid suppression with an H2 blocker or proton pump inhibitor to heal the ulcer, as well as antibiotic therapy of Helicobacter pylori infection, if present, to prevent recurrence. Fourth, patients with dyspepsia who have red flag symptoms, new dyspepsia after age of 45 years, weight loss, dysphagia, evidence of bleeding or anemia, these red flag symptoms. These patients should be referred for an early endoscopic examination. Fifth, other patients with dyspepsia who does not have red flag symptoms may be tested for Helicobacter pylori and treated first. Sixth, common treatment regimens for Helicobacter pylori infection include a 14-day course of proton pump inhibitor in high doses, such as ionosoprazole 30 mg twice daily or omeprazole 20 mg twice daily, along with antibiotic therapy, usually clarithromycin and amoxicillin. So, common treatment regimens for Helicobacter pylori infection include a 14-day course
of a proton pump inhibitor.
Proton pump inhibitor
in high doses like ionosoprazole 30 mg twice daily or omeprazole 20 mg twice daily, along with antibiotic therapy, usually clarithromycin and amoxicillin. Thank you very much for listening. This is all for our first case from the case files books about peptic ulcer. If you like, please like, comment, subscribe, and tell me what you think. And see you in the next case presentation, inshallah. Thank you.